Hello students, in today's video we will discuss physiology and pharmacology of androgens. Now this topic will include introduction to androgens, then their classification, regulation of androgens by hypothalamic pituitary testicular axis, then mechanism of action of androgens, their physiological actions, therapeutic uses and side effects. So let's start with a brief introduction to androgens. Now androgen is a Greek word, it means men. Androgens are male sex hormones and testosterone is the principal androgen in men. Testosterone is known as androgenic anabolic steroid. Its androgenic action includes development of male sex organs and development of secondary sex characters, while its anabolic actions promote growth of skeletal muscles and bone and also increase erythropoiesis. Now, testosterone secretion is much greater in men than in women. Now let's classify androgens. Androgens are classified as the natural androgens and synthetic androgens. So let's first talk about the natural androgens in men. Now as discussed earlier, testosterone is the principal androgen in men and testes produces testosterone, and testosterone accounts for 95% of total androgens in men, and testes produces 5 to 12 milligram of testosterone daily, and testosterone is secreted by the Leydig cells, and these Leydig cells, they are located in the interstitium of testes between the seminiferous tubules. So it is the testes that produces testosterone. Now apart from the testes, other minor sources of weak androgens is the adrenal gland. So adrenal cortex produces two weak androgens, namely dehydroepiandrosterone and androstenedione. These account for 5% of total androgens in men, and these are in fact inactive, and they exhibit their weak androgenic activity on partial conversion to testosterone in the peripheral tissues. Now in women, also as in men, there are two natural sources of androgens. Now small amount of testosterone is produced by corpus luteum in the ovaries and also by the adrenal cortex. Now, however, in contrast to the men, where 5 to 12 milligram of testosterone is produced daily, in women, total testosterone amounts to only 0.25 to 0.5 milligram per day. And therefore, the plasma levels of testosterone in adult male ranges from 0.3 to 1 microgram per deciliter, while in women it's only 20 to 60 nanogram per deciliter. So this is about natural androgens produced by the testes and the adrenal cortex. Now before proceeding to the classification of synthetic androgen, let's talk about certain important pharmacokinetic parameters of testosterone. Now, 98% of testosterone remains bound to proteins, that is a sex hormone binding globulin and albumin. Now, bound testosterone remains unavailable for action. Now, it is the free testosterone that produces pharmacological actions. Now, very important, metabolism of testosterone. Now, testosterone metabolizes to two very important bioactive metabolites, namely dihydrotestosterone and estradiol. Thus, testosterone along with dihydrotestosterone and estradiol produces its androgenic as well as anabolic actions. Now, the bulk of testosterone undergoes inactivation in liver by hepatic phase 1 and phase 2 metabolism to produce inactive metabolites. Now, these inactive metabolites are excreted in the urine. Now, because of this rapid hepatic metabolic inactivation of testosterone, testosterone has a very short plasma half-life of 10 to 20 minutes, and it's inactive orally and exhibits very short duration of action on intramuscular administration. Now, after classifying natural androgens, let's classify synthetic androgens. Now, testosterone derivatives have been developed to enhance intrinsic androgenic potency, prolong the duration of action, and improve oral bioavailability of testosterone. Now, first type of synthetic androgens are alkylated androgens, and these are 17 alkyl substituted derivatives of testosterone. For example, methyl testosterone, fluoxymasterone, oxandrolone, stanozolol, then danozol. Now, these alkylated androgens are water soluble and thus they are administered orally. And these are less androgenic than testosterone, and thus they exhibit sub-androgenic activity. Now, the main disadvantage of these derivatives is this, that they are hepatotoxic and they can cause cholestatic jaundice. Now, apart from this, alkylated androgens, when they are given in large amount, they may reduce serum HDL, that is high density lipid, and increase LDL, and therefore they are not suitable for cardiac patients. Now, second category of synthetic androgens are 17 beta esterified derivatives of testosterone. For example, testosterone undecanoate, then testosterone enanthate, then testosterone cypionate. These all are lipid soluble, and these are usually administered by intramuscular injection in oily vehicle, and some of them they are absorbed very slowly and exert prolonged effect, and these are not hepatotoxic. They possess little or no potential of hepatotoxicity. Now, third type of synthetic androgens are orally active compounds. For example, testosterone undecanoate, then mastrolone. These are orally active, and these show little or no potential of hepatotoxicity. Now, fourth type of synthetic androgens are derivative of 19-nor testosterone, for example, nadrolone, then nandrolone phenyl propionate. So, this is the classification of androgens, which include synthetic androgens and natural androgens. Now, let's talk about the mechanism of action of androgens. Now, this is a slide that explains the mechanism of action of testosterone. Now, testosterone, here represented by the capital letter T, is an agonist of androgen receptor. Androgen receptor is here represented as capital letters AR. So, testosterone produces its action by binding to the cytoplasmic androgenic receptors. Now, as discussed earlier, one of the bioactive metabolite of testosterone is dihydrotestosterone. And this dihydrotestosterone also produces its action by binding to androgen receptors. So, the mechanism of action of testosterone and dihydrotestosterone is very much similar. Now, look at this diagram. Now, in circulation, as discussed earlier, 98% of testosterone remains bound to a protein, that is a sex hormone binding globulin, and this testosterone remains unavailable for the action. Now, testosterone, as we know, is a steroid. The free testosterone, it passes through the cell membrane and it reaches the cytoplasm. Now, in the cytoplasm is present the androgen receptor bound to heat shock protein, that is an inhibitory protein. Now, as soon as the testosterone binds to the androgen receptor, this heat shock protein, it gets displaced, and there is formation of testosterone androgen receptor complex. And further to this, there is dimerization of this complex, and then this dimer of testosterone and androgen receptor, it gets translocated to the nucleus. This dimer binds to the coactivator and it interacts with a specific DNA sequence called as androgen response element. And this interaction causes activation of target genes, and thus messenger RNA specific for the androgen, that is specific for either testosterone or dihydrotestosterone, is produced, and that further causes synthesis of specific protein as directed by the androgen, and which further leads to the production of specified or the required biological action, that is the physiological response as required by the androgen. So, this is the mechanism of action of testosterone as well as dihydrotestosterone. Now, let's discuss the regulation of testosterone secretion in males. Now look at this diagram. Now this diagram shows hypothalamic pituitary testicular axis. Now this diagram depicts hormonal interrelationship between hypothalamus, anterior pituitary and testes. Now hypothalamus produces a gonadotropin releasing hormone which stimulates anterior pituitary to release gonadotropins, namely luteinizing hormone, that is LH, and follicle stimulating hormone, that is FSH. Now FSH is mainly responsible for stimulating spermatogenesis in the Sertoli cells. Now these Sertoli cells, they are present in the testes. Now these Sertoli cells, it produces a protein called as inhibin. Now whenever the levels of follicle stimulating hormone rise in the blood, inhibin inhibits anterior pituitary and that reduces the secretion of FSH. So this loop, which is represented here in the red color, this is called as a negative feedback loop. So as soon as the levels of FSH rise, inhibits anterior pituitary and that causes fall in the secretion of follicle stimulating hormone. Now on the other hand, LH, that is the luteinizing hormone, stimulates Leydig cells of the testes to secrete the principal hormone, that is the testosterone. Now whenever there is rise in the levels of testosterone in the blood, increased levels of testosterone directly inhibit the release of gonadotropin releasing hormone from the hypothalamus, which causes fall in the secretion of testosterone. And apart from this, increased levels of the testosterone also inhibit anterior pituitary, which causes reduced secretion of luteinizing hormone. That also reduces the levels of testosterone in the blood. And this loop again is called as a negative feedback loop. So whenever there is rise in the level of testosterone in the blood, there is reduced secretion of gonadotropin releasing hormone, there is reduced secretion of luteinizing hormone, and that reduces the secretion of testosterone and that causes fall in the level of testosterone in the blood. Now apart from this, as we have discussed earlier also, testosterone is converted to estradiol by an enzyme that is cytochrome P450 aromatase enzyme in the testes, liver and adipose tissue. Now this estradiol, it is a very potent inhibitor of gonadotropin secretion and plays a very important role in the feedback inhibition. Now rise in the levels of estradiol directly inhibits gonadotropin releasing hormone that reduces secretion of estradiol. Apart from this, again rise in the levels of estradiol also inhibits anterior pituitary to reduce the secretion of LH, that is the luteinizing hormone, and reduced secretion of LH again reduces the secretion of testosterone. So this is how secretion of testosterone is regulated by hypothalamic pituitary testicular axis and by the estradiol. Now let's discuss physiological actions of natural androgens in men. Now as discussed earlier, testosterone is the principal androgen, and this testosterone, it possesses androgenic as well as anabolic actions. So it is known as androgenic anabolic steroid. Now the primary androgenic actions of testosterone are the development of male sex organs and development of secondary sex characters, whereas anabolic actions of testosterone includes development of bones, development of skeletal muscles, and testosterone also stimulates the process of erythropoiesis, that is formation of RBCs. Now very important, testosterone, it is converted into two bioactive metabolites, namely dihydrotestosterone and estradiol. Now, testes produces about 5 to 12 milligram of testosterone daily, and 5 to 10% of this testosterone is converted to a more potent androgenic metabolite, that is dihydrotestosterone in the liver, hair follicles, prostate gland by an enzyme that is called as 5-alpha reductase. Now, around 0.2% of testosterone is converted to estradiol by cytochrome P450 aromatase enzyme in testes, liver and adipose tissue. So testosterone, along with its active biometabolites, that is dihydrotestosterone and estradiol, produces its physiological actions, that is produces its androgenic as well as anabolic actions. Now let's talk about the physiological actions of testosterone. Now, androgenic actions of testosterone include development of internal genitalia and development of secondary sex characters. Now, in utero, during gestation, that is during early intrauterine growth, Wolffian ducts differentiate into internal genitalia, that is fetal epididymis, seminal vesicles and vas deferens. Now, development of secondary sexual characters include growth of larynx and deepening of voice. Now, testosterone induces behavioral effects in men, that is increased physical strength, then male aggressiveness, penile erection and activation of libido. Now, apart from this, testosterone is essential for the process of spermatogenesis and maturation of spermatozoa. Now, anabolic actions of testosterone include development of bones and development of skeletal muscles. Now, testosterone is required for the epiphyseal bone growth, and that results in the increase in the length and thickness of the bones. Now, apart from this, testosterone induces mineralization of bones. The bones, they become wide and strong. Testosterone stimulates protein synthesis, and this protein synthesis further promotes muscle mass and strength. Now, apart from this, there is a reduction in the subcutaneous fat. Now, testosterone also stimulates the process of erythropoiesis by increasing erythropoietin, that is a hormone required for the synthesis of RBC, and testosterone also stimulates heme synthesis. So, this causes increased hemoglobin concentration in men. Now, talking about dihydrotestosterone. Dihydrotestosterone is a more potent androgenic metabolite of testosterone, and dihydrotestosterone is essential for the formation of external genitalia in men during gestation and its maturation during puberty. Dihydrotestosterone also stimulates development of secondary sex characters, and therefore dihydrotestosterone primarily shows androgenic actions. So, dihydrotestosterone is essential for formation of external genitalia, that is formation of scrotum, penis, male urethra in the fetus. Further, there is maturation of external genitalia during puberty. Glans penis, they enlarge in length as well as in the width. Scrotum becomes rugated, that is, it becomes rough and wider. Prostate begins to produce its secretion, that means it starts contributing to the semen, and there is development of seminiferous tubules which are required for the production of sperms. And apart from this, high level of dihydrotestosterone can cause prostatic enlargement in the old age, that is age more than 60 years in men, leading to problems like benign prostate hyperplasia or prostatic cancer. Now, like testosterone, dihydrotestosterone also induces behavioral effects in men, and the skin becomes very coarse and oily, and this can result in the formation of acne. Apart from this, dihydrotestosterone stimulates sexual hair growth during puberty, initially pubic and axillary hair, and then body and facial hairs. Now, in older men, that is in men more than 40 years of age, dihydrotestosterone primarily causes male pattern baldness. That is, high level of dihydrotestosterone can cause shrinkage of the hair follicles, causing male pattern baldness. Now, next are the pharmacological actions of estradiol. Now, estradiol exhibits anabolic action and it's essential for the development of bones. Now, estradiol and not testosterone is responsible for the fusion of epiphyses, that is epiphyseal closure after puberty in boys and also in girls, leading to the halt of linear growth. And estradiol further mediates mineralization of bone, and this increases the bone density. And estradiol activates male libido. It plays a very important role in sex arousal as estrogen receptors and aromatase enzyme are abundant in the brain. So estradiol is basically responsible for anabolic actions and activation of male libido. Now let's talk about the indications or uses of androgen therapy. Androgen therapy is classified as physiological androgen therapy and pharmacological therapy. Now let's first talk about the physiological replacement therapy. Now the sole unequivocal or undisputable clinical indication for testosterone administration is in physiological replacement therapy. Now physiological replacement therapy with testosterone is indicated in pathological organic hypogonadism and functional low testosterone. Now, pathological organic hypogonadism is a disorder of reproductive system, that is disorder of hypothalamus, pituitary or testes, leading to either no or severely limited production of endogenous testosterone. Now, in functional low testosterone, there is no organic disease of reproductive system, but endogenous testosterone production is absent or severely limited. Now, in both the cases, that is pathological as well as functional low testosterone, in both the cases, testosterone is administered so as to restore testosterone levels comparable to that of eugonadal man, that is comparable to a healthy man with a healthy functional gonads. Now, testosterone therapy provides not only testosterone, but it also provides dihydrotestosterone and estradiol, and therefore full spectrum of androgen effect is seen. Now, a transdermal gel formulation of testosterone is marketed for once daily application, and it is preferred for the treatment of hypogonadism and impotence. Now, let's talk about pharmacological androgen therapy. Now, there is no hypogonadism, and thus underlying cause of these indication is non-gonadal disease. Now, either natural androgens like testosterone, dihydrotestosterone or their synthetic derivatives are used. Now, pharmacological therapy of androgen is meant to produce required specific androgenic effect on muscles or bones or brain or any other tissue. Now, very important to note that pharmacological androgen therapy is now considered as supportive second line therapy due to the availability of more specific treatments. Now, in many clinical situations, however, androgen therapy remains a cost-effective option with long established efficacy and safety. Now, this pharmacological androgen therapy is a second line supportive therapy and is indicated in anemia due to renal and bone marrow failure. But the use of erythropoietin is the specific treatment. Use of erythropoietin is the specific treatment of this anemia. Then second use of pharmacological androgen therapy is in osteoporosis when estrogen therapy is contraindicated. Then in AIDS related muscle wasting, pharmacological therapy provides myotropic effect to increase the muscle mass and to increase the muscle strength. Now, apart from this, it is also useful in hereditary angioneurotic edema, which is a genetic disorder, and 17 alpha alkylated androgens like methyl testosterone, stanozolol, danozol increase synthesis of C1 esterase inhibitors, and therefore they are found to be useful in hereditary angioneurotic edema. Another second line use of androgen therapy is in endometriosis and estrogen receptor positive advanced breast cancer. Now let's talk about the side effects of androgen therapy. Now, serious side effects of androgen replacement therapy using physiological testosterone doses are rare. Now, synthetic androgens may produce side effects. Now, let's first talk about the side effects of androgen therapy in men. Now, rise in low density lipids and fall in high density lipids is observed, especially with 17 alpha alkylated analogs or derivatives of testosterone like methyl testosterone, fluoxymesterone. Now, secondly, apart from activating physical and mental activity, androgen therapy increases aggression and it also increases impulsivity. Now, being hepatotoxic, 17 alpha alkylated analogs like methyl testosterone can cause cholestatic jaundice. This we have discussed while discussing the classification of synthetic androgens. Now, gynecomastia can occur in children and men due to peripheral conversion of testosterone to estradiol. Now, apart from this, androgen therapy reduces synthesis of endogenous testosterone and it can cause oligozoospermia and testicular atrophy on prolonged use. Now, due to the increased activity of sebaceous gland, acne can occur in males as well as in females. Now, apart from this, early appearance of male pattern baldness can occur, and this androgen therapy can produce edema due to salt and water retention. Now, in women, androgen therapy can cause virilization, that is, characters associated with male like decreased breast size, male pattern muscle mass, then oily skin, excess body hair. Now, apart from this, it can also cause menstrual irregularities. Now, even though these side effects reverse on stopping the androgen therapy, but effects like deepening of voice, then male pattern baldness can be permanent after prolonged therapy in women. Now, in children or in young boys, androgen therapy can cause precocious puberty, that is early puberty, and child shows premature sexual behavior. Now, apart from this, stunting of stature or stunting of height can occur due to early closure of epiphysis. Now, contraindications of androgen therapy. Androgen therapy should not be given in prostatic carcinoma because it can cause further enlargement of prostate gland. It can further aggravate carcinoma. Then carcinoma of male breast, liver and kidney disease. Then apart from this, androgen therapy should not be given. It is contraindicated in pregnancy as it can cause masculization of a female fetus. It is contraindicated in men aged more than 65 years where it increases the risk of benign prostate hyperplasia and prostatic carcinoma. It should not be given to men with coronary artery disease or congestive heart failure because it increases the levels of LDL and reduces the level of HDL. And apart from this, androgen therapy can worsen sleep apnea, migraine as well as epilepsy. So this is in brief on introduction to androgens, natural and synthetic androgens, their mechanism of action, their regulation, therapeutic uses and side effects. Now, very important, information in this video is only for academic purpose for students from their examination point of view, and for treatment you are requested to consult your physician. And if you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.